Welcome everyone. We're really excited for this webinar. And my name is Kelly Horton. I am an alumna of the Friedman School, class of 2005. I completed the Food Policy and Applied Nutrition program, and in its place now the school offers a degree in Food and Nutrition Policy and Programs. And I'm super excited to introduce Dean Mozaffarian today. It's my pleasure to kick off this webinar for the school. Dean Mozaffarian is a cardiologist. He's a Jean Meyer Professor of Nutrition and the Dean of the Friedman School of Nutrition, Science and Policy at Tufts. He leads pioneering research on the dietary priorities to reduce cardiovascular disease, diabetes, and obesity in the US and globally, and on evidence-based systems innovations and policies to effectively reduce these burdens across the globe. Dr. Mozaffarian has served on numerous advisory roles, including for the US and Canadian governments, American Heart Association, Global Burden of Disease Study, the World Health Organization, and the United Nations. His work has been featured in the New York Times, the Washington Post, the Wall Street Journal, National Public Radio, Time Magazine, and many other outlets. In 2016, Thomson Reuters named him as one of the world's most influential scientific minds. Before being appointed to Dean at the Tufts in 2014, Dr. Mozaffarian was at Harvard Medical School and the Harvard School of Public Health for a decade, and clinically active in cardiology at Brigham and Women's Hospital. Today he will discuss the role of diet and nutrition and how they play in helping to bend the COVID-19 curve. I'm delighted to welcome Dean Mozaffarian as the first presenter for the new Tufts webinar series titled A Force for Good, Tufts on the COVID-19 Pandemic. Thank you, Dean Mozaffarian, for joining us, and I'll turn it over to you.
Thank you, Kelly. It's so nice to be introduced by one of our alumni. For folks who may not know the Friedman School very well, we are one of the leading institutions in the country and in the world that puts together the complex issues and challenges around food and nutrition, from bench science to food systems to communication to disparities, global and domestic hunger, and everything in between. We say we tackle nutrition from cell to society, and among our graduate programs and our research and our public impact work, I think our alumni are our best product, and so Kelly is one of our very successful alumni. It's wonderful to be introduced by you. I want to share my screen now to show my slides and get started.
And Dariush, while you're doing that, I'm sorry to interrupt. I forgot to mention there is a Q&A section in the Zoom, and if you have questions, feel free to leave your questions there. And as we get towards the end of your talk, Dariush, we will walk through those questions together. Sorry about that.
Great, thanks, Kelly. So the Q&A, it's a Q&A box at the bottom of the screen that you can float over. So I'm going to talk for about 20, 25 minutes and then leave time for questions. And I want to really think about what's going on and how food and nutrition are relevant to influencing and being influenced by COVID-19. So this was a graphic that we shared, and this was something that Tufts created a couple of weeks ago because, after the initial shock of what's going on with COVID-19, it's become really clear that food and nutrition are a big part of the story. These are just some of the major issues. I'm going to cover some of these. How food and nutrition is relevant to immunity, the incredible challenges to food insecurity, the very strong comorbid risks for poor outcomes from COVID-19, many of which are strongly diet-related. I'm not going to talk about this too much for time, but the particular issues around seniors and risk in older adults who have what we call hidden hunger, hidden micronutrient deficiencies and other more frank food insecurity that can predispose them to illness. Huge issues around disparities that are being seen, in particular, much higher risk among African Americans. The disruptions to all the production and supply chains around food, the major impacts for jobs in our economy, the importance of, and confusion, the importance of reaching out to the public and the confusion around these issues, And then lastly, something I really want to emphasize is the need for science, that a lot of this is early, and a lot of what I'm going to discuss is very, very early science, and we really need more research. Before we think about COVID, why do we care about nutrition at all? This to me as a cardiologist is one of the most important issues I can think of to help people's health and well-being. We have shown, and others have shown, that poor diet is the single leading cause of overall poor health on the planet, mostly from chronic diseases like obesity and diabetes and cancer and cardiovascular disease, also from food insecurity and undernutrition. So if you care about health, then food and nutrition needs to be at the top of the list. This is also a big issue for hunger and disparities, both in the U.S. and globally. It's a major issue for healthcare costs. I'll show you one slide on this. Healthcare costs have skyrocketed since 1970, and diet-related illness is a big part of that. That is affecting government budgets, that's affecting private businesses and economic growth. And since it's happened over 30, 40 years rather than over 1 year, this has not really received the attention it deserves. It's incredible economic burdens of poor nutrition. Our food system is also crucial to consider sustainability and climate change. This is so important. About 25% of climate change gases are from agriculture, 70% of the world's water use, 90% of tropical deforestation, loss of topsoil, stress to the oceans. This is the single biggest overall issue for planetary health. And then lastly, national security. Almost 3 in 4 young Americans can't qualify for military service, although they wish to enroll. And the number one medical reason, the number one medical disqualifier is obesity. And so Mission Readiness, a fantastic group of nearly 800 retired admirals and generals, has said that poor nutrition and childhood obesity are national security threats. So let's start with immunity. What do we know about food, nutrition, and immunity? There's actually quite promising evidence that multiple natural compounds that are in foods could really help improve the immune response and reduce the severity of COVID-19 infection. From a cardiovascular perspective, many supplements and individual nutrients have been tested for benefits in cardiovascular disease, and much of that has been disappointing. And so when I started reviewing this literature along with other experts at Tufts, such as Dr. Samin Maidani, I was skeptical. That individual nutrients or supplements might make a difference in immunity. But the evidence is actually quite compelling. There's a list of vitamins, there's a list of specific other nutrients, flavanols, and food extracts that really have interesting evidence for potential impact in immunity. The 4 kinds of categories of potential effects, which I think are really interesting for COVID. First, several of these have very good preclinical evidence in animal models, evidence in vitro studies, that they may specifically target COVID-19 proteins. We know that from studies with SARS, the SARS virus, which shares a lot of similarities with COVID-19. And so some of these nutrients may block entry of COVID-19 into the cells, and once it's in the cells, may block some of the key enzymes needed for replication. And so that's very interesting, the specificity of some of these nutrients against COVID-19 proteins. In addition, very good research has shown, including trials in humans, that many of these nutrients are crucial to boost and normalize immune responses, in particular cell-mediated immune responses, such as those that you need your white blood cell fighting soldiers like T cells that are really crucial to fight respiratory infections. And so there have been many studies showing that you need many of these nutrients generally to have an optimally functioning immune function. Third, and really interesting for COVID-19, is that many of these nutrients, in addition to boosting the healthy parts of the immune system, they blunt or soften or normalize the kind of crazy excess inflammatory response that can happen. And so they sort of return the immune system to what we would call homeostasis. So in COVID-19 in particular, most people die, get really sick, get hospitalized, need oxygen, go on a mechanical ventilator, and die because of excess inflammation. Their body's inflammatory response goes out of control, lots of reactive oxygen species, hyperactive inflammatory pathways, what we call cytokine storm, and that's what leads to the lung injury. This is very different, for example, from influenza virus. Influenza virus, usually what happens is people get a bacterial infection on top of the influenza, and that's what causes severe infection and death. In COVID-19, it's this excess inflammation, and many of these agents seem to blunt that. And then lastly, while this hasn't been done in COVID yet, many of these agents have been tested in human trials and do have some evidence for reducing viral respiratory infections, the symptom severity. And compared to some of the other drugs that are being tested right now and used right now, natural compounds have very, very attractive safety profiles. It's not as though there's no possible side effects. There are possible side effects. But compared to some of those drugs, the safety profiles of these natural compounds are very attractive. Now, it's much too early to go out and start buying, supplements and taking them to knowing that it'll reduce COVID-19. I'm not recommending people go take supplements to prevent COVID-19. But there is more than enough research more than enough science to do trials. And we're spending enormous amounts of money to deal with the economic consequences of COVID-19. We really need to be doing the research very, very quickly to see if we can address COVID-19 through these natural compounds. As I've mentioned, from my review, I think the evidence is stronger than for many of the drugs that are currently being tested with better safety profiles. So we really need to test these. And so Dr. Maidani and I are putting together a proposal, and I just want to share with you. We want to test a complementary combination of these natural compounds, which we think together will have an impact on COVID-19. I don't think any of them individually will have a major effect, but together they could really be complementary and synergistic. And we want to do a randomized trial to test, looking at, outpatients, nursing home residents, or even inpatients who've just been diagnosed with COVID-19. Can this, combination of natural compounds reduce clinical progression? Can it reduce progression to being hospitalized if you're an outpatient, or to being, put on a ventilator or dying if you're an inpatient? We estimate we would need about 2,400 patients in the trial to see what would work. And since there are 30,000 new cases every day in the United States, we think that we've gone through the protocol. We could do this whole study in 9 months and get an answer. Many of the studies that have been reported now with COVID-19 are testing 10 or 20 or 30 or 100 patients who are very, very, very sick on a mechanical ventilator and showing a little bit of a benefit. I don't think these natural compounds will have a major effect on patients who are at the very, very end stage of COVID-19 on a mechanical ventilator and very sick. I think these are much more important at the time of diagnosis. And so we're right now finalizing the protocol, and we're hoping to secure funding. Nutrition research and all research is expensive and takes time to do. So we're racing to try to get some funding and start this trial. Beyond the impact on immunity, what's really incredible is the impact of COVID-19 on food security, on hunger. There have been 34 million new unemployment claims in the last few weeks. That's 1 in 5 working adults in the United States. Just think about that. 1 in 5 of every working adult in the United States is now on unemployment. There have been 124,000 school closures affecting 55 million children, many of whom get half of their calories at school, and when they go home, there isn't enough food. Restaurants are closed, which is about 20% of calories, and while takeout is open, it's much, much less than normal. In addition to restaurants, worksite cafeterias, school cafeterias, university dining halls are closed, which is where many people get their food. And the supply chains are disrupted. So the normal transfer of food from one place to the next has been totally disrupted. And that's causing, at the same time there are people not getting enough food, there's remarkable food waste. And, one might ask, well, why don't we just, get the food from the farms to the supermarkets or to the people? And our food system is so complicated and so fragmented that it actually doesn't work that simply. It's not that straightforward. And I'll just give you a few examples. One is milk, right? A huge amount of milk is consumed in school and in dining halls and in lattes. Some of the major coffee chains in the United States, they sell actually more milk per volume than coffee per volume. And so with all of those things closed, with schools closed and coffee shops closed and all those things, people just aren't going to go home and make lattes and espressos, and kids aren't going to be drinking milk in the same way that they might at school. So even if you got it to grocery stores, people won't buy it. I think two other really interesting examples are potatoes and onions. So these are two of the most common vegetables served in restaurants. Something like 80% of restaurant meals have either potatoes or onions in them. And if you think of all the ways they're used, French fries most prominently, almost every restaurant has French fries as a major side in many of its meals. And of course, fast food restaurants, it's the major side. And onions, beyond onion rings, onions are used in salads, caramelized onions, they're used all the time in restaurants. There's just, people just don't go to the grocery store and buy potatoes and onions and go home and make French fries and onion rings the way they eat them when they go to restaurants. And so there's huge amounts of those two particular vegetables being plowed under because there's just no way to get them to people where they would use them. Now, what I think is amazing, you may have read some of these statistics yourself. What's amazing is most of these statistics are not great. There's actually shockingly little data. There's shockingly little real-time surveillance, monitoring, understanding of these issues, of what are the impacts on food security, what are the impacts on nutrition and diet quality. And this is a tremendous research need, and I think this highlights the need not only for research now, but to really change our approach to the food system. To be able to tolerate and handle future threats, we need much better systems of surveillance and monitoring than we have now. What we have now are just the ability to do some polls, online polling, and ask questions, which isn't the same as real hard data. This is one example that was shared by colleagues at the University of Arkansas. They were already doing some polling when COVID broke out, and so they had some questions about food insecurity. This is just one survey, so it doesn't represent hard data. But what's interesting is they found that food insecurity has risen in the United States to almost 40% of Americans report food insecurity, which means not having ready access to enough food to feel comfortable. 30%, 2 in 5 Americans, and you can see this is particularly a problem in the southern United States and southeastern United States, where 1 in 3 Americans are reporting food insecurity, but really every region of the country is affected. This is an unbelievable problem that's happened so rapidly. In terms of jobs, I mentioned the jobs, and there's a lot of news about the job loss. I think what's not well understood is how much of that actually relates to food. And so, people have written about and thought about the travel industry and how their jobs have been affected, and the entertainment industry and other things. But by far the biggest losses of jobs have been in food and beverage. So 11 million jobs, or almost a third of all the unemployment claims, are from the food and beverage industry. So this is another way that food is crucial and interrelated with COVID, is that this crisis has struck hardest in the actual where we get our food. What I'm particularly worried about, and also see as an opportunity as a cardiologist, is the information coming out on diet-related comorbidities and COVID-19. Really striking risk of poor outcomes if you have some of these conditions. And so this was one analysis from New York City, which was excellent because it adjusted for multiple risk factors simultaneously. It adjusted for age and sex and race and smoking and all these other things. And what they found is, even adjusting for all of these things simultaneously, if a patient, if an American diagnosed with COVID was obese, they had a more than 4-fold higher risk of hospitalization. If they were severely obese, a 6-fold higher risk. If they had diabetes, about a 3-fold higher risk. They had heart failure, a 4-fold higher risk, and even hypertension, which is extremely common, about a 20% higher risk of hospitalization. Those are the risks for just individual conditions. So if you had, for example, obesity, diabetes, and hypertension, which is very, very common to have all three of those, you would have a 16-fold higher risk of hospitalization from COVID. So this, and this has been seen, this is just an analysis from New York, but this has been seen in other US analyses in the United Kingdom, in Italy, and in China. Everywhere that's looked, diet-related comorbidities especially dramatically increase the risk of poor outcomes, dramatically. How? We don't have specific research in COVID yet, but based on what we know about these diseases, these are probably the likely drivers. First, all of these conditions are linked to reduced immune function. Diabetes, hypertension, obesity, heart failure, we know that patients with those conditions, their immune function is not ideal. Secondly, all of these diseases have a common thread of chronic systemic inflammation as a driver. And so, I wonder, and others I think are wondering, whether given COVID-19 is this inflammatory disease, it's kind of like pouring gasoline on a smoldering fire. For obesity particularly, we know patients with obesity have reduced lung function because of the excess mass around their chest. And that's been seen with influenza, for example, that obese patients aren't able to handle the respiratory stress of respiratory infections. And then lastly, the drivers of these diseases include the major two biggest drivers by far are poor quality diets and physical inactivity. And we know that independently of diabetes and hypertension and obesity themselves, poor diets will give us, low immune relevant nutrients, and physical inactivity worsens metabolic health, inflammation, and immune regulation. So I think all four of these things together provide a very good, hypothesis for why these are such a problem. And Americans are really, really sick. Half of adults have diabetes or prediabetes, more than half have cardiovascular disease, and 3 in 4 adults are overweight or obese. So more Americans are sick than are healthy. More Americans have these risk factors than don't. And so we asked the question, what would COVID-19 have looked like if we didn't have this additional pandemic of poor metabolic health in the United States? And so this is an analysis that we've done. We've just submitted it for publication. It's not published. We said, what percentage of COVID-19 hospitalizations in the United States do we estimate are attributable to diabetes? This is a modeling estimate of how many of the COVID-19 hospitalizations could have been prevented if we didn't have the epidemic of diabetes in our country. And what we found, we estimated that 28% of all COVID-19 hospitalizations may have been prevented if we didn't have the rates of diabetes that we do. This is particularly age-related, less of a problem in younger adults, more of a problem in older adults. And when you look at racial and ethnic disparities at any age, diabetes explained worse outcomes and more hospitalizations among Black and Hispanic Americans than among white Americans, consistent with some of these higher rates of hospitalization that we're seeing. For example, for a 50 to 64-year-old Black or Hispanic adult, 1/3 almost of hospitalizations were attributable to diabetes. When we looked at obesity, it's even worse. Obesity, as I said, is a pandemic in our country, and we estimated that 2/3 of COVID-19 hospitalizations overall were attributable to obesity. And when we put the 4 risk factors in the New York study together, obesity, diabetes, hypertension, and heart failure, we estimated that 80% of the hospitalizations that we've seen, which could mean 80% of the deaths as well, are attributable to these poor metabolic conditions. And so, this really suggests that in dealing with COVID-19 and future pandemics, improving metabolic health is an absolute priority. If we're spending trillions of dollars to deal with the economic consequences of shutting down our economy, we should be spending a similar amount to improve metabolic health in this country, because that could have prevented the need for the dramatic hospitalizations and stress. And I want to end with those ideas that I think one of the potential positive outlooks around COVID-19 is it's reaffirmed and brought important attention to the importance of public health and science. I feel personally that public health and science have always been kind of, little cousins that are not paid attention to compared to some other business or defense or other priorities. But public health and science are crucial, and COVID-19 has really highlighted that. And this is an op-ed that I wrote with James Stavridis, the former Fletcher School Dean at Tufts and the former NATO Supreme Allied Commander, the Supreme Commander of all the Allied military forces. He's a four-star admiral. And what we talked about is, for military defense, we've recognized that the U.S. military's hard power, the actual, might of the military, is very effective, but has to be complemented by soft power. For the military, soft power is all of the investments we make at the Department of State and other places in diplomacy, economic development, trade, foreign aid, sanctions, promotion of education, and so on. Soft power has been recognized and heavily invested in the United States for military, for national security. All generals, all departments of state, the Department of Defense recognize that soft power is a crucial complement to hard power. For healthcare, on the other hand, we essentially have only hard power. We have this highly trained, highly resource-intensive, very effective healthcare system, but that's hard power. That's the acute response to a threat. We need healthcare soft power. We need public health, education, surveillance, scientific research, better designs of our schools and workplaces and communities, food policy, and more. And so the gap between soft power and hard power in health is enormous. And we've been working on some of these issues with a wonderful advisory group that's been helping us think through some of these issues. Folks like Dan Glickman, Tom Harkin, David Kessler, many others who have significant expertise across academics and government, and we're hoping to come out with a series of reports and recommendations. One of those, which we hope to come out with next month, is how to strengthen nutrition research and policy. And these are some of the recommendations there that we're going to share. Two of the most important recommendations are to increase cross-agency coordination and to increase investment and structure in nutrition research at the National Institutes of Health. I'm just going to talk about a couple of these very briefly. First, I think a really interesting and important idea is to create a new Office of the National Director of Food and Nutrition. After September 11th, the country realized that we had excellent, amazing national intelligence services across the CIA and the FBI and others, but that it was fragmented and that it wasn't coordinated. And so the Congress created the Office of the Director of National Intelligence, the ODNI, and the Office of the Director of National Intelligence is a cabinet-level office that reports to the Office of the President and now coordinates national intelligence. And it's been seen as an extremely successful and effective way to coordinate our national intelligence investments. Our national investments in food and nutrition are at least twice as large as our national investments in intelligence. If you go across all of the food programs and agricultural programs and research and other things, and yet they're fragmented and not coordinated across, Health and Human Services, USDA, the CDC, the FDA, Medicare and Medicaid, NASA, the Department of Defense, the VA. It's kind of amazing. Almost every aspect of the federal government touches food and nutrition. And so we propose a new office, a cabinet-level office, an Office of the National Director of Food and Nutrition to coordinate national food and nutrition policy and research. There's other things that we think are important. For example, adding a new 28th institute at the National Institutes of Health, the National Institute of Nutrition. This should be additive and complementary to all of the research that's already going on at NIH to really try to address some of these cutting-edge issues. And so this was a quick overview of, I think, some of the big issues of how food and nutrition are bidirectionally affecting and affected by COVID-19. And I want to close, at Tufts, we believe that nutrition is not just a scientific discipline, it's an agenda. And I really believe it's time for a national moonshot to strengthen and fix our food system, to leverage food as medicine, to incentivize and shift to real food, to build a strong public health and food infrastructure, and to rapidly expand critical nutrition research. As the vice chair of the British Medical Association said recently about the UK, but just as true for the United States, a massive campaign on diet would save lives and change the course of our nation's health forever. And I can think of no time where this is more important or timely than with COVID-19. So thank you very much, and I'm happy to answer questions and discussion.
Thank you so much, Dari. That was very informative. We have nearly 500 participants listening into the webinar, and we've got some great questions. We may not be able to get to all of them, but I've been looking through, and let's start with the first questions were about the study that you described. The first question is the specific anti-COVID-19 activity demonstrated in vivo or in vitro, e.g., for example, cell culture? Could you talk a little bit about that?
Yeah, so most of the studies that have, this is how you determine efficacy against certain proteins are cell culture or in vitro studies. But then against SARS-CoV proteins in particular. And again, some of the SARS-CoV proteins share over 90% homology with COVID proteins. But in addition, some of the work has been done, there's been extensive work in animal models on these nutrients and impacts on a range of respiratory viruses. Not much with SARS because that hasn't been studied that much, but with other coronaviruses, the common cold, many of which are coronaviruses, influenza, and many other viruses. And so, there's imperfect evidence, which is why, again, I wouldn't tell people to go start taking these supplements as nutrients, although I do think that we should be talking about it in terms of healthy foods. So there's imperfect evidence to go start taking these as supplements, but there's very compelling evidence to do a trial.
Right. Could you also comment on beta-glucan as a compound that might be useful?
So I don't have a lot of expertise in beta-glucan, and so I'll have to look that up and provide comments and feedback. I haven't done a lot of work myself in immunity, and so this is something that I'm trying to rapidly learn, and again, working with wonderful Tufts faculty to really develop our own platform for research.
Okay, great. We had two questions that are different but similar, so I'll just ask them both, and you can choose how to answer. The first is, what are the natural compounds to be tested in the proposed trial, such as goji berry, turmeric, green tea, elderberry? Are you using any of those? And then the other question, similar but different, which specific nutrients will you be studying?
Yeah, so I think that we have a pretty good sense of those compounds, and I think when we finalize that, we will. And again, hope to get funding. It's shocking for people not in research how long it takes to get research funding. If we wanted to go through NIH, we would need to submit. You get a score on your grant, 4 months later, and you get the funding 7 months later. So we're going to try to go to NIH, but that would mean starting a year from now. So we're also going to try to go to some foundations and others for funding. And so when we've finalized all that, we'll release that and put that up on clinicaltrials.gov.
Great. We got a really long question. I'll try to distill, but there's several points to it. One is, why not include B12 into the study? This questioner ties in the Kawasaki disease that we're seeing in some of the kids, and not knowing whether or not that's related. Is that something that you're looking at with vitamin D deficiency?
Yeah, so there have been some studies, and so in terms of some nutrients and COVID so far, so B12 is something that has more of a longer term effect, and also has some potential side effects, and so I don't, it's something that we can certainly look at. The nutrients that have been looked at and in COVID so far are selenium. In China, areas that have low selenium in the soil have much higher risk of poor outcomes than areas that have normal selenium. We can't say that that's relevant to the United States because there isn't selenium deficiency in the United States the way there is in China. China has some historically selenium deficient areas, so I don't know that it's relevant. And also, there's been selenium supplementation in those regions, and so China believes that they've mostly eliminated the selenium deficits, And that's just, again, an ecologic study. There could be other differences between those regions. So selenium has been looked at. There was much made of one report of low vitamin D in patients with COVID, if people saw that. If you look at the study design, they basically just retrospectively looked at people who happened to get a vitamin D measurement and also compared them to other people in the hospital. The people who happened to get a vitamin D measurement could have been people that the doctors were worried about low vitamin D, and so that's not a very strong design to implicate vitamin D. Certainly vitamin D has some general immune effects that could help with COVID. So it is, again, kind of amazing that we haven't stockpiled sufficient nutrition research to address this, right? What if we had 10 years of a National Institute of Nutrition and, a couple $2 billion a year in nutrition research funding, and we'd figured all this out, and COVID hit, and we could just, say, great, let's implement what we know, right? So I think we need to be proactive and really, expand our nutrition research effort to have knowledge for future pandemics. The other thing I'll say, though, is I do think it is I don't think it's the right time to recommend people go take supplements until we do the research. I do think it's the right time to recommend people go eat healthy foods that are rich in these compounds and other compounds. And, people say behavior change is hard, but look at the radical change in culture around social distancing and mask wearing and other things. And of course, some people aren't doing it, but the vast majority of the country has changed their behavior and is listening to public health messaging. And so to me, it's such a missed opportunity that the governors and our federal leaders aren't, at the same time they're talking about social distancing and wearing masks, they're not talking about physical activity, really go out, a couple of them mentioned it, but really go out and exercise. And more importantly, everybody's cooking at home now. And we don't have great information on what that means. It could mean some people will cook and eat much healthier than ever before. It could mean that some people are going to buy, the worst food that's already prepared and have worse diets. And sales suggest both of those things are happening. Why are we not having daily public health messaging to go out and eat healthy diets and exercise? That could have even a 5 or 10% effect on COVID, could be huge, right, for what we're dealing with.
So on that note, and we've got a couple of questions to that, what would be some of that advice? We've already got a lot of that information. What would be some of those tidbits of messaging that should be out there?
Yeah, well, I think, there are certainly specific fruits and vegetables and other things that have these compounds in them, bell peppers, and we did a commentary on this list. I won't go into the list now. Happy to share that. But I think that generally we know from many studies that if people change their diet composition within 4 to 5 weeks, they can have dramatic improvements in blood pressure, dramatic improvements in diabetes, dramatic improvements in inflammation without weight loss. This has been shown in very well done randomized trials like DASH, Sodium, OmniHeart. Other excellent trials have shown that diet is rapid and diet is powerful. So if you eat a pattern of more fruits and vegetables, more nuts, more beans, more minimally processed whole grains, seafood, you reduce, refined starch and sugar, you reduce processed meats, reduce highly, the foods that are highly processed with lots of sugar and salt. Very rapid improvements in metabolic health. And so I think public health messaging should emphasize that. And whether you call it sort of a high-fat DASH diet or a Mediterranean diet or just kind of healthy eating, I think most people know what healthy eating looks like. And the challenge is that it's not been normalized. It's more expensive. People don't know what to do with the foods when they buy them because many people don't cook. So I think that this is a multidisciplinary challenge, and again, when our economy is collapsing and we're literally spending trillions of dollars a month to try to prop this up, we should be using some of that investment to go to one of the fundamental hearts of the problem, which is poor metabolic health from poor diet.
Great, thank you. We have a couple questions. I'm going to try to merge into one. We have at least one dietitian on here who works with Native Americans and has asked the question about, they seem to be, Native Americans and Alaskan natives seem to be missing from some of these studies. We have another person who has also pointed out Latin America and the Caribbean, and asking the question, what do you think will be some of the lessons learned from COVID-19, specifically for these populations in terms of nutrition, healthy diets, physical activity?
Well, we know that Native Americans have remarkably high rates of diabetes and obesity, much higher than the rest of the American population, and so that could be dire for COVID-19. They don't represent a large proportion of the population in some of the studies that have published on this yet. I mean, the hot spots were on the coasts, right, where people came in from overseas, and so California and Washington and New York and Boston, and so I think as COVID-19 starts to go into the center of the country, and it's just starting to do so, then this could be really dire for Native American populations. I think that one possible positive is that when you start getting to low-income rural populations around the world, some of the rural populations in Africa and rural populations in India and other places, their relatively low rates of diabetes and hypertension and obesity could partially protect them from severe outcomes. There's still going to be a lot of deaths because they don't have the social distancing, and so it's going to sweep through the population. So the numbers may still show a lot of deaths, but I think as a percentage of actual infections, some of those rural low-income regions could be protected. The cities in Africa, the cities in India look like the United States. They don't look that different, unfortunately. So they're going to be hit hard, I think.
There's a question about, has there been a comparison of COVID-19 hospitalization and deaths across countries with various obesity prevalences?
Yeah, so we thought about doing that. I showed you the paper that we have, just the analysis that we just did within the United States. So I've thought about doing that as well. The trick there is that, first of all, diagnostic cases are strongly determined by testing, and testing is different in every country, and so you'd really want to follow deaths. Deaths are inconsistently reported. Some countries are actively not trying to report COVID deaths because they don't want to sort of terrify the population. Other countries are more complete in their reporting. And then lastly, countries have very different time frames of when the virus hit, what they did for social distancing and other things. And so I think that we've thought about that, but those challenges would make the analysis quite tricky, right? You'd have to sort of simultaneously adjust for when the virus went into the country, what they did for social distancing, what the reporting biases are. And so I think better studies are studies that look at these risk factors within the same population, like the New York City study, where you don't have all these differences, right? Everybody's kind of tested in the same way. There's not all these confounding factors. So I think as data get better, then maybe analyses like that could be tackled. But I don't think the data is good enough to do a strong analysis like that.
Okay, great.
It's a great idea.
Yeah. We're running short on time, so I'll just ask you one more question, which I've kind of been formulating in my mind as an amalgam of a couple of these questions. As we know, the U.S. government stimulus package has included some funds in there for USDA around food and commodities. Some of the questions are, how do we influence the purse strings around these things? And, is there some conversation going on with Tufts and USDA around how to maybe spend that money? And then another question, sort of just lumping us in there, is what about partnership with the food industry? Are there any of those conversations happening?
Yeah, so, again, things have been happening so fast, and at Tufts, the first few weeks of March were really focused on keeping, courses and research and everything active at Tufts, and so we've really shifted to kind of more of a public focus the last 5 or 6 weeks. In the last 5 or 6 weeks, we've had great conversations with World Central Kitchen and Jose Andres and given them some advice and input on their strategy to use restaurants. I personally haven't spoken to anyone at USDA, but I know several of our faculty are aiming to put in some research funding for USDA. Most of the funding that's been passed so far in the first 3 COVID packages has been just to expand funding for things that already exist, like expand funding for SNAP, to add funding through pandemic EBT for kids that are not in school. So, there hasn't been a lot of new funding for anything new, right? It's been just to expand what's there. I think that data and monitoring and surveillance real time of what's going on is crucial, and so I think that USDA has started to put out a couple of calls about that, but pretty limited. So I think that's really important for Congress to realize that we need more data. I think that science and rapidly promoting science is important. And again, NIH is amazing. NIH is the jewel of research, but it's slow. So there needs to be faster ways to get the funding to studies. I do think that innovation in food industry is crucial to fix the problems that we face. We do have links to several companies, and I think those conversations should start. I think everybody's just been kind of just getting their bearing and getting their balance, and I think now's the time to start all of those conversations. Oh, you're muted, Kelly.
Thank you. Thank you so much. This has been really informative. We've got lots of questions, but unfortunately we have to wrap up. One of the questions we had was, will you be pushing this out on social media? So I do want to let folks know this has been recorded. It will be posted on the Friedman School's website. And I'll put in this plug that you didn't know I was going to do, but Dr. Mozaffarian has a wonderful post on his LinkedIn page. He also has a Twitter account, so you can interact there and continue the conversation. Any last words as we wrap up?
Yeah, I think we need everyone thinking about this, and the more people that know about these remarkable bidirectional links between COVID-19 and our food and nutrition system and what we eat and what we put in our body, the more we can get the message out that this is important. Our state and federal leaders are overwhelmed, and so they don't have bandwidth to research and understand these issues themselves. And so I think sharing this information with government leaders at state and federal levels is really important, and I hope everyone on the call will email their representatives and let them know that there are some big food and nutrition opportunities to help with COVID-19.
Great. Thanks all for tuning in, and looking forward to keeping this important discussion going. Thank you so much, Dr. Mozaffarian.
Thank you so much. Okay.
Bye-bye.
Bye-bye.